Happy birthday to you.
Holds my neck up.
Today's the first in work ever in 2020, and I thought about it. This actually made me feel like I could dress a little bit down. Maybe it's the wrong answer. I don't know.
Did you get a donut? I know. Well,
How are you? Good. I do have those slides. If you want bigger, fine slides. Yeah. So these are all the other presentations. You do and you don't, but so
Yeah. I think not to have aspersions on the industry, but I think they have some value. Okay. Well, I mean, told me that I guess
And sometimes you go to clients about
representing Tool and they said, we don't see
and you cannot, that's tech, but even to a further extent where it's casual.
homemade, actually.
Always having to shift and route from one client to another and addressing
from 9:30 to 11, then we'll turn it over to my fellow commissioners for the second of the meetings this morning. We have a pretty full agenda here, not so much in terms of like decision-making stuff, but in terms of a lot of information to digest and figure out which direction we're going with and stuff. So our today is more of a kind of discussion-oriented meeting than it is a decision-oriented meeting. But there are obviously some things that will show up in decisions. So let's see. The first thing we need to do is, do we need to approve minutes, David?
I believe we do.
Okay, it's not on my schedule, but I believe we do need to approve the minutes from the meeting of October 2nd. Anyone wishes to make a motion?
So moved.
Second. Any discussion or corrections on the minutes or comments? Okay, all those in favor of approving the minutes? Aye. Anyone opposed or anyone abstaining? Okay, so the minutes are approved. What we want to do today is three sorts of things. First, talk about some of the annual cost trends report. There are a couple of issues there that we want to go over. Second is the Office of Patient Protection annual report from last year. And then third is the issue of administrative complexity, which we have dealt with some, and so update us on what's going on in the commission, what's going on outside of the commission, and so on. But before we dive in, let me turn it over. David, Happy New Year.
Happy New Year. Good morning, everyone. Thank you for being here. So as you said, Chair Cutler, a packed agenda today. Do just want to give the commissioners and the public just a sense of the timing for the cost trends report and what to expect next. So today we're going to be going through a presentation of some of the new findings that we've prepared for this year's cost trends report, specifically on the topics of variation in provider health system performance, as well as new data on hospital outpatient spending trends. I would say the variation in provider organization performance is an analytic work that we have done before, but we have enhanced this work and we have updated it with some new specific looks into how providers are performing, specifically on low-value care, which is an important topic for the commission. The work on hospital outpatient and looking at some of the trends is new work for this commission, and I do want to just give a shout out to the research and cost trends team, because the sophistication with which this team has evolved in terms of our data analytic abilities and going into claims data and really mining some really crucial insights into how care is shifting and changing in the payments for those services, especially in the hospital outpatient area, which is an area that is less easy to kind of dive into. You have to look in the claims data. This is publishable work. This is really sophisticated work that frankly no other or state and many other research organizations nationally do not have the capacity to do. So this is really exciting work. I'm really proud to be able to walk through it with you. But we are going to walk through the findings. We are still working on the written version of the cost trends report. So this is a great opportunity for you to ask questions, clarifying questions, context questions, questions about where we go next, and get your input and feedback as we're finalizing the written report. We do expect to be able to give that written report in draft form to commissioners very shortly for you to be able to review in whole and provide feedback to that as well. The goal and the hope is that at the February 5th board meeting that we would have a final discussion on the report and be able to push that out publicly. So a great opportunity today. Nothing's totally finalized, so a great opportunity to get your feedback and input on the report itself. For the other topics, the Office of Patient Protection Annual Report, this is something that we love to check in every year on the activities of this really important part of our agency, and do expect that after today's meeting that we will push that public report to our website and post that as it's more of an administrative annual report, an operational annual report. So with that is just a little bit of a preview, and so you get a sense of where we are in timing for the cost trends report. I am going to turn it over to David Auerbach, our research director here at the Health Policy Commission. I would note that the findings here are a subset of what's in the total report, and we had presented a bunch of findings at the last board meeting and a bunch of findings at the cost trends hearing. So really this is kind of the next in the series of great findings. So with that, I'll turn it over to you, David.
Okay, thank you. That's right. So today we are going to go over the main findings in the cost trends report, but we will spend more time on material that hasn't been presented yet and kind of hit the highlights of some of the material that has been presented. And in a few cases, there's a new take on it or an update to some of that prior work. And before I start, I will just say, I want to acknowledge the team. You'll hear from a few of us today, but not all of us, but everybody has been working hard in this report, especially Sarah Sadownik, Deputy Director, who's had her fingers on the entire report. And so you'll hear from 3 of us today, and they'll come up at the right times. So today we will go over the main sections of the cost trends report, the overview, trends in spending and affordability I will talk through. Then the provider organization performance variation section, which is part of the chart pack, which is a separate compendium that goes along with the cost trends report. I'll present some of that material too, and then we'll move to the hospital section. And I do want to echo what David said. The hospital outpatient part especially is very hard to study, and it took a lot of work. So keep that in mind. It's such a diverse, mixed bag of things that it's hard to characterize in a clean way. So we end up doing a lot of examples and case studies, and that's what you'll see today when we get to that part. Okay, for the overview. This is our famous trend of, which we show every year, of spending growth in Massachusetts in the orange and the US in the blue, and we showed this at the cost trends hearing, but I'm showing it again partly because the US numbers between then and now have been updated from preliminary to final. And you see that we did maintain our streak of, I think, 9 years in a row of being below the healthcare spending growth nationally. And here's the updated trend on just the commercial sector, where you can see since 2013 we have also been below commercial spending trend, and that's a cumulative difference of about $7.2 billion, which is how much less we have spent in our commercial market compared to if we had grown at that national rate for the 5 years. Okay. Now I do want to put that in a little bit of context as well. So what we just showed was commercial spending defined as just the commercial claims part of spending. And it turns out that our commercial performance relative to the US is a little different depending on how you define commercial spending. And that's what this slide is about. So what we just showed was back here, the orange and blue, that's what we call TME, or total medical spending. And here you see we grew over the 5 years in total by 12.9%, compared to about twice as rapid spending in the US. Now when we look at that middle set of bars, we're moving from commercial spending, claim spending, to premiums. What's different is the premiums include the insurer administrative costs. That's not in the commercial spending. And when we look at that, and also it does not include the out-of-pocket spending that patients pay. So in that look, we still are significantly below the US trend, but the gap is a bit smaller. And that's because our administrative costs have been rising a bit faster than those in the rest of the country. And then when you go to the third set, what we're doing is removing the individual market, just removing the connector and looking at employer premiums only. And there, the gap is really quite small. We're not gaining much in terms of lower spending than the rest of the country. So what you're seeing from the second to the third set is the success of the connector in having low spending and low spending growth, and also increasing enrollment over this time period. So this is partly explaining why our premiums in the employer market have not really come much closer to the US average. So, yes.
Question on the all premiums, individual and employer.
Yes.
Why are we not looking at, given the large population over 65, what we're spending on MedSup, Medicare Advantage, and things of that nature? Are you looking at that in a different way?
It's a good question. We just don't capture a lot of that Medigap spending. It's not captured in the GEA data that we have to work with. You can see it in some context in the national data, but we don't have a comparison for it. Yeah.
We are including comparisons on Medicare in the report.
Yes, yes, we talk about Medicare Part A and B spending, sure, yes.
Which
But
is
this,
national.
yeah. Yes.
Hey, David, do you have any explanation of why the connector premiums would be lower?
Yeah.
And when you take them out, we're comparable to
Yeah,
national spending?
yeah, that's a great question. We should have. They would be great at giving those reasons too. And from what I've learned and gathered over the years, it's a number of things at once. For example, we had a head start on the rest of the country for one in setting this up in 2006-07. They've developed a competitive market with a lot of options, and they have a few things such as default enrollment into one of the lowest two cost plans, which creates a structure where they want to keep those premiums low to capture that enrollment for one thing. What else did some of the features?
So in the commercial market, they're making
Yeah.
richer plans, is that?
Well, it's not about the benefit generosity really. Those turn out to be the same after the subsidies are
The
added.
provider networks differ. So the
Provider
connector
networks
plans
differ.
tend not to go to the most expensive providers. They're not in network so much.
That's right.
Okay.
Most of
That's helpful.
the connector plans that have low premiums, which are about a third below the employer market, are not including partners, for example, and they're paying providers at lower rates, more comparable to the MassUp MCO or MassUp ACO rates. And they started out there. A lot of them have a lot of MassUp MCO membership as well, and so they're able to, for whatever reason, they're able to pay those lower rates. So those. Number of other reasons, but it's really an important thing.
Yeah, and I would add, we have a more generous subsidy, which has been able to keep enrollment in some of the most price-sensitive kind of populations here in Massachusetts, where we have a RAP program that has been able to keep the health insurance affordable for people. Keeping them in the market helps. Individual mandates still having a piece of that. There's a great, I think, a Health Affairs article that was written, I think, this year about why the connector in particular has been such a success, and the second lowest individual premiums in the country.
Yeah.
So a great testament and success in that competitive market there. And as David said, a lot of it, there has been enrollment shifts into that market over the last couple of years as well, both kind of churn from the Medicaid program, but also smaller employers and others perhaps not offering coverage anymore or shifting some of those employees onto the individual market.
Okay. So here's a highlight on those employer market premiums, which are so high. This is just comparing the states of family premiums between 2016 and 2018 averaged. And you can see that we were the third highest across the states. And I also want to note here that those bubbles on top are showing the 90th percentile family premium. And this is the total premium, the employer and the employee part combined. And that dot is really $30,000, meaning that 10% of Mass residents, their family premiums are costing more than $30,000 a year, which is a lot of money. And this is a new finding that was somewhat surprising to us, but going back to just the employee portion of those premiums, so what employees pay for coverage directly out of their paycheck. And we've broken down those premiums or those businesses into 4 groups. Those with the lowest wages in the yellow, and the highest wages on average are the 4th quartile you see in the like orange on the bottom. And surprisingly, firms with the lowest wage employees in the yellow charge more for those employee portion of the premium than the other firms by a lot. By 2018, it's really risen above the pack there, and it's about 50% higher, over $8,000 a year is required for your employee contribution for that family premium if you are at a low-wage firm compared to higher-wage firms. And we don't know exactly why that is, but it's kind of a counterintuitive finding, and it's important to track, and it certainly gets to the issue of affordability. Okay. And I've shown this before again. The rapid rise in premiums from 2016 to 2018 was much faster than wages. And what that ends up meaning is that earnings growth over the last 2 years, about 40 cents of the dollar, about 40% of it went to healthcare, more than people took home in their pay. And it's an important point to remember that the healthcare system is absorbing a lot of income gains in the state, and we should understand and think about if that's something that is commensurate with the value added. Okay, so in the next section, we're going to go through some of the highlights of the provider organization performance variation work that we have shown before in past presentations, and now we're including in the chart pack along with some of our other routine reporting. We feel confident enough in this material, and we've done it a few times, that it's going to be part of our standard reporting. So just stepping back a second, the chart pack will have 4 subsections this year. And a lot of this we presented at the cost trends hearing: hospital utilization, post-acute care, alternative payment methods, and this first section will be called POPV. There it is. Okay. So just to introduce the section a little bit, what we have done is we've taken from the claims data spending and utilization that we see among members, and we attribute them to their PCPs, and those PCPs to their provider organizations, so we can compare organizations to each other. In past years, we've only included claims from Blue Cross Blue Shield, Tufts, and Harvard Pilgrim. This year, we've expanded that to include Neighborhood, which is now Always, and Anthem Blue Cross Blue Shield. So we have a broader view of commercial spending. It adds up to about 900,000 Mass residents in 2017 that we have claims for. And where in all cases except for low-value care, all the results we were showing will be adjusted for age, sex, health status, insurer and product type, and sociodemographic variables related to the person's community: income, employment status, housing status, and so on. So we want to capture any social determinants in health that might be causing the differences in patient population at one provider org versus another. We don't want the results to be swayed by those differences.
David, can I just make sure I understand the sample for 1 second?
Yes.
So 900,000 is a lot less than the 6 million.
Yeah.
So
Right, so
Medicare, I wouldn't have guessed Medicare and Medicaid were all the rest. So I'm sort of.
Yeah. The full commercial population is about 4 million in the state.
Yeah.
And so, so what is 900,000? I think our insurers represent about maybe 2/3, I would guess, of the market. So that would be about maybe 2.5 to 3 million. And then the others that we don't have, we're missing a lot of the self-insured because of GoBay.
Oh, I see.
So that's probably the biggest section we don't see.
I see.
And then there are some people we can't attribute to a provider or provider orgs that are too small that we don't see.
Okay.
So that probably explains, yeah. But we feel like this is a representative enough sample to give a good sense. Okay. So starting out with total spending. And this is again claims-based spending. It doesn't include non-claims settlements or other things that go into the non-claims. And here you see the provider organizations are ranged from highest to lowest spending. They're sorted by the adjusted spending. We're also showing in the blue the unadjusted spending for comparison, but they're pretty similar. And the takeaway here is there's pretty large variation in total spending. And you see, for example, the highest spending organization, Partners, on the left, and the lowest spending is Atrius on the right. And that means that if I'm a patient and my primary care physician is at Partners, on average, my spending is about 33% higher, or $1,500 a year, than if my PCP is at Atrius, adjusted for all things that might be different about me. And Atrius and Reliant, as we've noted before, the physician-led groups tend to have lower spending, and we've talked about that in the past. Okay, some of the utilization measures. This is ED visits, and we are showing total ED visits in the light blue and potentially avoidable ED visits in the dark blue. And you see a large amount of variation here too. We have shown before that BMC tends to have high ED visits among their attributed patients, and UMass is on the left, it's fairly high as well. And Atrius and South Shore are on the right, with their avoidable ED visits less than half of those of the higher organizations. And the statewide averages are in those hashed lines above.
These are risk adjusted?
Yes, these are adjusted for all the things that I showed in the front.
So even given its poorer population, BMC still has very high rates.
Yes. Their population is also younger for whatever reason. So yeah, it's their commercial population. It's not the people that just go to the hospital, right? Right. Okay. Yep. mental health ED visits also vary, not quite as much, but a significant amount. And we see some of the same provider ordering from left to right. Okay. There's more in the full chart back, but I want to go to the low value care section next. We have reported on low value care before, and each year we have been updating and adding several new measures and keeping some old ones that we continue to report on. We had to make some changes because of ICD-9 to ICD-10, which was a pain. We had to redo all of our coding, and it's difficult. So these are the 7 measures we looked at this year. This is, of course, a small slice of the entire world of low-value care. And even among these 7 measures, we found a total of $13 million in low-value care spending in 2017 among these 900,000 members. About 100,000 members had at least one low-value care service, and 163,000 services, so more than one per person on average who got some low-value care. And they're divided into screening measures, preoperative testing, so the kinds of routine testing someone might do before an operation, and procedures. And I'm combining several of these onto one graph for efficiency purposes. This one shows the 3 screening measures that we looked at. And what these numbers mean is per 100 eligible patients who could have gotten a certain screen, like for example, T3 testing is a thyroid-related test. It's only done potentially for people who do have a hypothyroid condition, but this test adds no value, as Choosing Wisely campaign and doctors have decided, or learned from the evidence, and still these tests are performed on about between 5 and 15 of 100 eligible patients. And you see variation in the stress testing, and vitamin D testing is still performed to a pretty fair extent on an overall population basis, even though it's down from prior years. Okay. Here we're covering the preoperative testing and procedures that are low value. You see pretty high bars on the orange. These are baseline labs that are shown to have no value, that are often routinely done before an operation. And you see variation across provider orgs in performing these labs, from about 21 per 100 patients who are going to have an operation to about 1 in 3 at South Coast. And you see variation in the upper procedures as well, which are performed less frequently, but can be quite expensive and invasive to the patient. Yes?
Why are they done? Legal reasons?
Great question. I'm sure it's a combination of answers. I mean, often there's just organizational inertia, and people just do things because that's how they are done and that's how they've been done. And sometimes financial incentives don't help, but I wouldn't say it's entirely financially motivated. But do you have any other additions, Laura, to that?
Yeah, we talked to several clinicians about low-value care services at one point in time, and some of the primary care doctors say, I know this is low-value care, but the surgeon isn't going to operate unless I do X, Y, and Z, because they are used to that practice, and so they still order the test even when they know it's low-value care in order to move their patient along in the process. And I think it is, like David said, it is not purely financial. It is a little bit of a legacy.
Yeah.
The pre-op section.
Oh yeah, Washington State, right. So, yeah, some states and organizations have caught on to this and launched active campaigns. In Washington State, they found similar things with the preoperative labs and other preoperative tests, and have started a campaign called Stop the Pre-op, which is catchy, to try to, break into this bureaucratic administrative inertia that can just set in as to this is just the way we've always done it, and try to change practice, which is hard.
And David, these 7 measures, it's generally accepted that they're low value.
Yes.
Is it Choosing Wisely? Did they identify these specific?
Are these all from?
measures?
I believe they're all from Choosing Wisely. Some of them might not be, but we definitely chose measures that are in the literature, well accepted, across a number of studies and so on. Yeah.
The biggest thing that comes across here, to me, is the overall rates as opposed to the variation in the rates across the
Should I get to the
systems.
next one? Yeah.
Yeah.
Right. And And so here what we're seeing is it's kind of hard to condense them all into an overall rate, but we can add up the spending, which we do here. We add up the spending on low-value care services per 100 eligible members across organizations, and this is what you see. And we have to say that the spending is combining both the rates and the price and the cost per low-value procedure. So that's partly why you see partners up on the right, is that I think their rates are higher than average, but maybe not the highest, but they do have the highest cost per test, for example, for vitamin D. So you see partners Leahy Wellforce on the higher end, Atrius BMC Reliant on the lower end. Yeah. And the bubbles are the size of the number of members in each organization. Yep. Okay. Okay, good. So that's our quick tour through the provider organization performance variation. Now I want to get into some of the hospital results. And we will start and go fairly quickly through the first two because we have presented them before. But I'll soon call Laura up to go through some of this material. Trends in inpatient severity of illness and trends in inpatient commercial volume are the two subsections of our inpatient part of the cost trends report. Okay, so this graphic we have shown before, and I just want to bring it to your attention again. This is showing this somewhat of a paradox that started a lot of this investigation, which is that commercial inpatient volume in the blue has dropped year after year since 2013. So fewer and fewer patients, but at the same time, spending has increased each year in the yellow, from 3.6 billion to 4.1 billion. And so what's going on here is if you divide the spending by the discharges, you find that spending per commercial discharge has increased 5.2% per year from 2013 to 2018. And that's an increase from about 14,500 per hospital stay to 18,700. So this is what we're trying to delve into and understand. And when we break that down, it looks like the causes for the spending growth, despite the fewer patients, is really two main causes: prices per stay for the same exact stay, and an increase in the severity or acuity of these stays, which seems to contribute about as much as the price increase, both growing at about 2.2 to 3% per year. And the acuity increase we've talked about a little bit, and we will go through, is again puzzling and hard to figure out. And we've done a lot of work to try to understand this. And I want to note that the payments are proportional to that acuity, so it functions as almost as another price increase. But before we go into the hospital, I want to review this graph again. This is showing risk scores by payer. It's another look at the same phenomenon of this rising acuity, but instead of looking just in the hospital, the risk score is a patient's overall severity of illness or sickness over the course of the year. And the risk score is used mainly by the payers, but in lots of quality measures as well. And each payer tracks the risk score of their patients and reports that to CHIA. And here you can see by payer from 2013 to 2018, on average, the risk score of the full population grew 11.7% over the 5 years. It's really a massive increase. In a fairly stable population, we would expect this to be pretty flat. And in the pre-file testimony, we asked some questions of the payers and providers. What do you think is going on here? And a lot of folks responded, oh, it's the population aging, or it's an increase in the burden of disease. And even though there is some aging in the state, of course, and it does vary by payers. Some are affected more and some less. Overall, we did some work to model this out, and we found that the aging of the population over these 5 years just explains about 0.5% of the 11.7. So it's tiny overall. Again, it might vary. Some payers might have more of an aging population, but overall it mostly offsets itself. We also tried to understand the underlying burden of disease, which is really hard because we're looking at, this is often revealed through coding, which is part of what we're studying in the first place, and providers can control the coding. But if you look at CDC data based on self-reported, I have diabetes, I have arthritis, you see overall, we don't see an increase in the burden of disease there either. We see the prevalence of some things going up, some things going down, and it looks like it's pretty much offsetting itself. You can look at life expectancy, and it doesn't grow over this time period. So there's nothing really that we can find that suggests that we're getting sicker as a state.
When you want to go to Aetna, docs there are doing a much better job.
You're right. And we haven't thought too hard about the differences by payer. You know, we can see it's true that their populations do change a little bit, but maybe we will follow up with some of them.
David,
Yeah.
do we know when the ICD codes changed?
That was 2015, yes. So I don't think it's a big factor here. Well, we showed before, hospital by hospital, their own case mix, and it does seem to be play a little part of it, yeah, but not the majority. Okay, so I'll now introduce Laura Nasuti, who's going to walk through the rest of the hospital inpatient material and use the clicker.
Hi, good morning, Commissioners. Katya is also joining me to talk about some of our outpatient results in a minute. But first, we're gonna review this slide that we have seen before. This slide is, we are looking at coding intensity here. And what we have tracked over the time period of 2013 to 2018 is we have looked at the increases in acuity, which for both DRG systems is greater than 10%. And because we're looking at coding, we looked in the data for other markers of severity of illness, such as length of stay, and there we don't see a real increase that corresponds to the increase in acuity. And we also looked at ICU days and saw that was going down. Since the last time we presented this slide, we also did a sensitivity analysis, including intermediate ICU. Some of the literature suggests that intermediate ICU is more like normal beds, but we wanted to throw that in anyway as a sensitivity to see potential changes. And there we still saw by 2018 a negative 1.5%. So even considering intermediate ICU didn't really change that result. The other thing I want to mention from our last presentation is that we saw this across all DRGs. So even though we're going to do a couple case studies, we really saw this almost uniformly across all DRGs and an increase in severity. There are two ways in which we are noticing that this increase in severity is happening, or acuity is happening. One is that within the individual DRG, we see that the severity level, the proportion of the highest severity levels looks to be increasing over time. So on the left in this graph, we have the DRG for chronic obstructive pulmonary disease, and we see from 2013 to 2018 that the highest severity level went from 3% of the total population with this DRG to 10%. What this means financially, for instance, for MassHealth, these are MassHealth payments on the right, is that for somebody who would have been coded as severity 3 in 1 year and then moving to severity 4, in another year it's almost 2 times, it's a little under 2 times the payment. I want to say also that, again, ICU and length of stay does not correspond with this change in severity distribution. The other thing that I want to talk about is the potential to switch from one DRG that is a lower acuity DRG to a higher acuity DRG. And this appears to be happening in the case of septicemia. So septicemia is a very serious, very severe illness. There are awareness campaigns that are tracking it and trying to promote early identification, and we are in support of that. However, the researchers have also come out to say that the way we classify septicemia in especially administrative data in DRGs is highly variable and subjective. And so when we were initially led to these results because we noticed this huge increase in septicemia from 2010 to 2018, 180% increase, and a corresponding decrease in DRGs for conditions that can lead to septicemia, like pneumonia and UTI. So when we talked to researchers about this, it was interesting because they said, oh yeah, we know we can't use administrative data to study trends in septicemia. We have to have clinical data because there is so much coding of septicemia that is not, that is more on the margins. Coders have latched onto this. There is coding blogs and groups that help promote the coding of septicemia, which again, if it is true septicemia and it is early detection, that is great. But unfortunately here we see that there is also a financial incentive to be aggressively coding septicemia because the payments for a septicemia DRG in the commercial claims data, these are average commercial claims payments, go from $12,000 for pneumonia to about $23,000 for septicemia. So that is where we were with our coding intensity work. The other part of the inpatient, in the inpatient setting, the other part of the inpatient story is this declining volume, because one of the things we have heard is, well, wouldn't you also see more severe cases if all the low severity cases are going into the outpatient setting? So while we do find, and we'll talk about this in a minute, that some of our decline in scheduled admissions is because we think some of this volume is going into the outpatient setting, the severity of what is leaving does not map to the huge increases in severity that we're seeing remaining in the inpatient setting. So for commercial inpatient decline from 2014 to 18, we see about a 9% decline, and about half of that decline, a little under half of that decline, is due to declining birth rates, and the other portion is due to scheduled admissions. Because these are the two causes, we think that declining inpatient admissions might be a trend that will be continued in subsequent years, and we will continue to monitor that. Among maternity admissions, all hospital cohort types are losing maternity admissions over time. However, they are losing them differentially. In particular, high public payer hospitals are losing them much faster than other hospitals, which has implications financially for the hospitals, as well as it means that women are bypassing their local hospitals, either because of choice or because of provider, their prenatal care provider affiliations. And so we see that decline specifically among the high public payer hospitals. This is a slide that we showed briefly at the end of the last inpatient decline presentation that we gave. And here in that presentation, we talked about several case studies where we see a potential switch from inpatient to outpatient. In this instance, we focus on hysterectomy because hysterectomy had a large number of surgeries, and we could track this more easily over time. So in this graph, I just want to call out that the dark gray is inpatient change in volume, and so to the left of and most of these are to the left of the bar, indicating that there was a decrease in inpatient volume. The light gray is change in outpatient volume for hysterectomies, and most of these happen to be on the right of the side, indicating that indeed there truly is a shift from inpatient to outpatient for hysterectomy. However, as we look at this graph, we can also see that the bottom half of the systems are losing overall hysterectomy volume, and several of them happen to be what we think of as lower priced health systems, whereas in the top, they have net gained volume, and net gained volume is that bar in orange. And so you can see that Partners at the top has net gained the most volume of hysterectomy. And so when we talk about shift from inpatient to outpatient settings, there are benefits for the patient, but we also think of it as a cost saving to go from inpatient to outpatient. However, when we look at total inpatient and outpatient hysterectomy spending, from 2015 to 2017, we still see a 9.5% increase in payments. And so why is that happening? And so that led us to dive further into what is happening here at the system level. And so this is just one example. It's a hypothetical example, or it's a real example, and we're just imagining what would happen if a patient made certain choices. So here we have the Good Samaritan Hospital, which actually lost the most inpatient volume from 2015 to 2017. And we have Brigham and Women's, which gained the most outpatient volume of any individual hospital in the Commonwealth from 2015 to 2017 in our cut of the all-payer claims database. So here we see that within a hospital, if a patient stayed within Good Samaritan and instead of having a hysterectomy inpatient had that hysterectomy outpatient, it would have resulted in savings. Same with Brigham and Women's. So it would have been 22 to 26% cost savings to stay within the same hospital. However, if this patient, instead of going to Good Samaritan inpatient, ended up at Brigham and Women's outpatient, this would have actually resulted in a 37% higher payment. So shifts from certain inpatient settings to outpatient settings may actually be cost increasing. And again, these are, we don't know for sure where any individual ended up. We can just look at the overall trends and see, back to this slide, that the outpatient, that the partners group, for instance, is gaining a lot of outpatient volume.
I just want to stop and kind of underline this particular slide. This is, I think, a really important finding and a nuance to just to kind of underline what Laura said. We often think of the shift to inpatient to outpatient as being cost savings. But when patients are moving across systems and moving to higher price systems, that shift can actually be cost increasing, spending increasing. And we know that, of course, many systems and institutions are considering significant expansions of their outpatient services and service offerings. So it's really important to understand what are the payment levels, what is the underlying variation of those payment levels, and where are patients being drawn to or from, all of which can have different dynamics in terms of the overall spending. Again, within Brigham and Women's, a shift from inpatient to outpatient is cost savings. But it's when patients move across the systems and knowing that there is this underlying variation that it can have a different dynamic. And so this is, I think, one thing that as more and more care is being shifted to the outpatient setting, I think important for us to understand what is the underlying variation in the payment levels in the outpatient setting, and that's something Katya is going to even show us a little bit more, because we do see, as we all have known, variation in the inpatient prices. We do see that as well as in the outpatient sphere as well.
Great, yeah, and so with that, we are going to talk about our work in outpatient spending growth. And I'm going to do a little table setting for that before Katya goes into some of our results. So here this is the only place for the rest of the presentation that we're going to talk about all payer. From now on, it's going to be commercial, but we put this up here because in an all payer world, we know that hospital inpatient is a very important part of spending, and it's actually more than hospital outpatient. However, when we restrict the world to just commercial spending, hospital outpatient actually accounts for 60% of all hospital spending and 25% greater than 25% of all commercial spending. I want to take a moment here to talk about what hospital outpatient spending actually means. So hospital outpatient spending is the component of a visit or a surgery that is paid as a facility payment directly to the hospital and does not include any professional fees. So often in the case of something like a surgery, you have both the hospital or facility payment as well as additional professional payments. But here, these pies in the next two graphs only talk about that hospital payment portion. And also, hospital outpatient does not just mean services received up the street at MGH. It could also mean services received at the MGH Waltham facility, as an example. But any of those off-campus facilities that do charge a hospital or facility fee component to the services they provide. Here, we wanted to look at how important hospital. Another way to look at how important hospital outpatient spending is. It is the largest contributor to commercial TME growth from 2015 to 2018, growing at about 3.6% per year. We wanted to understand what was within a hospital outpatient, and here we see that administered drugs are the fastest growing at 44%, but outpatient surgery is growing from 2015 to 2017 at about 11%, and still accounts for the largest section of the pie, 34% of our spending. We know that 20% of all commercial revenue, for commercial hospital revenue, is also from that outpatient setting. And so with this,
From surgery.
From surgery. Oh, so from surgery. And so with this, we wanted to go and dive deeper into surgeries, and instead of just looking at the hospital outpatient spending component, we also wanted to bring in those professional spending, because whenever there is a hospital outpatient service, there's often a professional spending that comes with it. So with that, I'm going to give it over to Katya to talk about how we examined outpatient surgery encounters.
Good morning, everyone. To analyze surgeries happening in outpatient hospital settings, we created surgical encounters by grouping together all procedures provided to the same patient on the same day that were related to surgery at the same hospital. And we classified them according to HRQ methodology into major, minor, and neither. Major surgeries represent about half of all hospital outpatient surgery spending, and those include invasive, mostly therapeutical surgical procedures.
You want to advance the slide? Yeah, okay.
Sorry.
Mostly therapeutic surgical procedures such as hysterectomies, arthroscopies, cataracts, and different kinds of knee repairs. Minor surgeries account for about 28% of hospital surgical spending, and those are procedures that don't require incision, unlike major surgeries. And many of those are diagnostic in nature, such as breast biopsy, colonoscopy with biopsy, or endoscopy with biopsy. Not all hospital outpatient spending coded as surgical on a claim could be considered as true surgery. About 24% of hospital surgical spending are in this category, and those include such procedures as earwax removals or intrauterine device placements that most people would not recognize as like real surgery. Surgical encounters include hospital part, as Laura said, which is what we presented so far. But there are also professional fees, and those are often payments made to surgeons, anesthesiologists, and also some lab tests. In the discussion to follow, we will include those professional fees to estimate the total average spending for the given surgery. Per member spending grew for both minor and major surgery buckets during 2015-2017 time period, but drivers were quite different between these two buckets. Growth in major surgeries was higher at about almost 10%, driven mostly by the increase in average payment. And in turn, that was due to the increase in payment to facilities, not to the professionals. Payment to facilities was 10.2%, while payment to professionals went up by 4.8%. As you can see on this graph, total number of major surgeries didn't change much over this period. So it is understandable that all the increase in spending came from payments or prices. Overall complexity, which we attempted to measure with relative value units of the main surgical procedure on a surgical encounter, that complexity didn't change much over the period as well. So we can be sure that the price increase do not represent surgeries becoming more complex in nature on average. However, there was plenty of variation among top surgical procedures that we looked into in detail, and some went up, some went down. For example, we showed you before the example of hysterectomy, which went up by 30% per member during this period because of inpatient to outpatient switch. Also, there was quite high increases in myringotomies, which are ear tube placements, and tonsillectomies, adenoidectomies. If we subset it to a children population and look at increases per children population, since those surgeries are mostly done in children, the increases would be up to 20% per child, which is pretty high. But that was counterbalanced by the decline in other surgeries. However, as we say, on average, complexity of the average major surgery have not changed over this period. Among minor surgeries, the drivers of spending were quite different. Overall, total spending increased by 6.8%, and that was predominantly driven by the increases in volume. Prices have increased very little. Both facility prices and professional prices have increased very little. And here, I'm saying interchangeably prices and payments. What we mean here is average payment, which is collection of different prices for different procedures on the surgical encounter. Again, there was plenty of variation among minor surgeries. However, in minor surgeries, there was much more concentration of volume in just a few procedures. For example, 30% of minor surgery volume was just colonoscopies. When I say 30%, it's in terms of spending. 30% were colonoscopies, and those went up in volume, their price went down, and that's what partially contributed to the pattern that we see here. What is different about minor surgeries relative to major surgeries is that for most of the minor surgery procedures, there is a real competition outside of hospital environment. Out of top major surgeries that we reviewed, very few have considerable non-hospital volume in the non-hospital professional-only settings. But among minor surgeries, many surgeries have healthy competition from non-hospital settings. For example, same example of colonoscopies, about 30% of colonoscopies with biopsies happen in non-hospital environment. So that could be one of the factors that helped to not to increase or even cause price decline. And this is something that we would like to investigate further in our future work. To demonstrate to you price variation in major and minor surgeries, we selected top 3 surgeries and showed you top 6 hospitals in volume, sorted from highest volume to lower volume. And the median shown here with orange dotted line represent a median across hospitals with volume of 10 surgeries or more. So it's not median of the shown 6 bars on a graph. Here you can see that partners AMCs typically lead both in volume and in prices for the surgeries that we show. And just let me note here that cholecystectomy is the gallbladder removal, and excision of knee meniscus is like a type of a knee surgery. And hysterectomy we talked already about. You can see here that partners, AMCs, get about twice as much for performing a given surgery than another high-volume hospital with the lowest price here. For example, for cholecystectomy, the difference is about like 12,000 going to MGH and about 6,000 paid to South Coast for cholecystectomy. Similarly, for hysterectomy, two partners hospitals were getting over 20,000 for outpatient hysterectomy, while the same surgery could have been performed at BidMAC for about 11,000. And I must say here that we also explored how different is the complexity of those surgeries across the providers. And overall, there is no much difference, with only exception of MGH providing more complex surgeries than the rest. At the same time, Brigham and Women have the same price as MGH, but complexity is the same or lower than others that we show here. Another interesting issue about surgeries is that those are very concentrated in a few hospital systems. As you can see here, partners by itself account for 20% of major surgeries in volume and 28% of major surgeries in spending. Overall, as you know, there was a lot of merging activity recently, and partners added Massa-Inier, while Beth Israel merged with Leahy and added a few other hospitals. And if you take all those hospitals that constitute those top two current systems, the overall concentration would be 52 to 53% in spending or in volume. So, and that is not even including like additional affiliated hospitals, just owned hospitals. Here we show you similar pattern in price variation for minor surgery, although there is slightly less price variation, as you could see. Again, we hypothesize that could be the effect. That could be that could be due to the fact that there is more competition from non-hospital settings. Here, also, partners AMCs lead the way in volume and prices, and they are about 40 to 50% higher than the median that we show. And we show here breast biopsy, colonoscopy with biopsy, and endoscopy with biopsy. Similarly, concentration for minor surgeries is high, and it's even higher for partners. Now, partners is 25% in terms of volume of minor surgeries and 30% in terms of spending on minor surgeries. When we look at the current affiliations in the top two systems, Beth Israel, Leahy, and partners, again, the number of concentration would be 52 to 53%.
Great.
One thing that I wanted to mention, but kind of forgot. Can we go back to the price slide, one of them? There are other hospitals that have even higher prices than partners AMCs. And those not just those like island hospitals that have very few numbers of volume. Those are hospitals that enjoy geographic monopolies and still have like healthy volume, like Cape Cod hospitals, which includes Falmouth and Berkshire Medical Center. Their prices are often higher than even MGH or Brigham and Women, without obviously not being high in complexity of provided surgeries. Their volume is not so small either. Usually they are about around median in terms of volume among other hospitals, or even above. So we hypothesize that this is something caused by the fact that they have geographic monopolies and patients are not willing to travel too far from their home. And hospitals use that fact.
Yes. Okay. Great, thank you.
The overall, do you want to do the overall?
Sure, I was just gonna, did you have another point? Yeah, go ahead.
No,
Okay,
yeah,
right. So those are the highlights, and I think we saw pretty clearly that commercial hospital outpatient spending growth is driven mainly by payments per encounter or prices, and it's the hospital portion of the payment that was the largest driver there. And a shift towards higher cost or higher payment hospitals is also an important component of the overall spending increase. We saw a high concentration of volume in the higher price settings, and despite the fact that inpatient to outpatient shifts do and can save money, this is offset or counteracted by shifting to higher price systems. So that's, at least from what we can tell from the hospital outpatient world, these are the biggest drivers. But some of the other components we're going to continue to come back to in future work.
David, can I just ask one question about this, which
Yes.
I think is really neat?
Yes.
Do we know how much of the volume is occurring in the downtown academic center versus in the
We were just
satellite
talking about that.
facilities?
Yeah, Laura, what do you have to say about that?
So starting in 2016, there is a place of service code that indicates off-campus hospital, but as of the 2017 claims data, we still don't have a lot of confidence in being able to, in our claims data, and being able to identify the on-campus versus off-campus. Obviously, this needs to be fixed or improved upon at some point, because there is a bunch of implications for site-neutral policy payment and being able to actually see in the claims data what is happening on campus versus off campus. And it's one of our, when we get the 2018 data, we will be looking to see if we can better distinguish those. But as of now, we have not found clear markers.
In addition to site-neutral, it's also, my sense is most of the teaching and research is happening downtown, not at the partners Waltham.
Mm-hmm.
So the argument, which is, gee, we should pay super high prices because we're supporting all this extra goods and uncompensated care and so on. I don't have the sense they're doing a lot of uncompensated care at partners Waltham, and maybe they are, and I don't know about it, and research and teaching there. But so to the extent we knew that, we would be able to talk a little bit more persuasively about it.
Yeah.
Yeah. We should have more on that.
I'm curious, David, what the next sort of piece of research is in your mind on this, because if I take that example of hysterectomy with Good Samaritans to partners, is there a way to figure out what's driving that? I realize that's a hypothetical, but what's driving the shift? Is it reputation? Is it the doctor's relationship with the other provider? I'm curious.
That's a good question. On that topic, one piece of research that we are trying to do now is to just make sure there's no quality difference. And we do have at least one outcome measure that we believe we can understand in the claims. But as to what's driving that shift, I think that's been a topic of a lot of the work of the MOAT committee and Team MP. And they've described this cycle of, do you want to describe the cycle, of, let's see if I can remember. You have higher commercial margins for the AMCs, which they then use to invest in facilities, invest in providers. They will sometimes, often, I'm making a claw, but purchase physician groups who then encourage them to refer to their hospitals. So a lot of it is through referral, and this cycle reinforces itself to some extent. And but it's hard to track a specific patient who is shifting and figure out exactly what's going on. I wish we could. Some of that will come to anecdotal and other evidence.
One additional analysis that we're working on is looking at shifts of physicians and how physicians are affiliated with the major systems and how that is perhaps changing, and where we see, obviously, physicians are highly part of the big systems in Massachusetts. There's not a lot of quote-unquote independent, primary care physicians left, but we also see that there is perhaps a lot of competition among the systems for physicians, and so we want to be able to try to understand that dynamic as well, which can play into referrals.
Okay, let's, in the interest of covering all the topics, thank you. Let's move along to the Office of Patient Protection Annual Report.
Good morning, Commissioners.
Morning.
As David said, this is an opportunity for the Office of Patient Protection to come before you and discuss the work that we've been doing, and to give an overview of what is in our annual report, which will be released today.
So this is Nancy, the Director of the Office of Patient Protection.
So just as a reminder, OPP has sort of 4 main duties. The first is offering an opportunity to consumers to purchase insurance outside of the open enrollment period through our open enrollment waiver process. The second is administering an external review process and regulating an internal appeal process for consumers with private health insurance. And the third is to do the same, sort of regulate internal appeals process and administer an external review process for patients of accountable care organizations and risk-bearing provider organizations. And our third is sort of a catch-all. We operate a hotline, we answer emails, and we're sort of willing to answer questions and concerns about healthcare access and health insurance for residents of the Commonwealth. And the first slide details sort of the outcomes of the 2018 open enrollment waiver process. In 2018, we saw a huge increase in the requests that we received for open enrollment waivers. As you can see, it's twice the previous 2 years. And this is definitely a trend that has continued into 2019, as last year we received over 1,300 waiver requests. And we can't pinpoint an exact reason sort of why we've seen this increase, but I think it goes back to sort of more knowledge about the open enrollment waiver process and the Office of Patient Protection, and also back to what David said, that there is an increase enrollment in individual health insurance coverage, which is the population of people who need to abide by the open enrollment waiver process and can come to our office for that. And as I said, one of the duties of the office is to regulate the internal appeals process at insurance companies. So insurance companies in 2018 reported to us that they received just over 13,000 member appeals. And these are member appeals of any type, not just dealing with medical necessities. So these are consumers who had some type of issue of non-coverage that they wanted to challenge with their health insurance company. And you'll see 48% of these consumers had a favorable resolution from going through this process with their health insurance company. And these are similar to previous years, similar numbers to previous years that we've seen. And a little under half of these member appeals dealt with sort of clinical decision-making or medical necessity appeals.
Are there particular plans which draw the most appeals?
Yeah, we have a graph in the report that is member adjusted for enrollment that sort of highlights which plans had most member appeals and which plans had the fewest. This year, Fallon is at the top of that, and it goes sort of all the way down to Anthem, which is the lowest. And in 2018, OPP processed 231 eligible requests for external review. We received just over 300 requests, and about 76% of them were eligible, getting us to the 231. And as you can see, 42% of the consumers who came through OPP were able to have their issue resolved in their favor. And so, getting coverage or getting sort of authorization to go ahead to get a service that would be covered by their health insurance company. In the annual report, we break down pretty specifically, actually, around certain categories of services for people's services that they requested. Here is again just a snapshot of the medical surgical eligible external reviews versus the behavioral health external reviews, and similar to previous years, there's a higher rate of behavioral health reviews getting resolved in the consumer's favor. But overall, actually, these numbers are a little bit lower than last year. But it sort of changes year to year. It's hard to have any sort of rationale or reasoning behind it. But there is sort of a larger win rate, so to speak, for consumers with behavioral health claims. slide represents a new area for OPP. This is RBPO or ACO external review and internal appeal process. So this is for patients who are commercially insured, who are patients of a risk-bearing provider organization or an ACO certified by the Health Policy Commission. If they have some sort of disagreement with their provider, they can appeal that internally to their provider organization, and then they can also come to the Office of Patient Protection for similar process to the health insurance external review to have that resolved. These are issues around, as you can see on the slide, mostly referral restrictions, and there's a small subset of internal appeals at the provider organizations that dealt with type or intensity of services. And it's a small number in 2018, and OPP's external review process related to RBPO and ACOs only went live in September 2018, so in those last 4 months of the calendar year, we didn't have any external reviews. We have received some in 2019. And in 2018, we responded to, I would say, well over 1,800 inquiries. This really only counts the calls that we received. And I included a quote from one of the consumers that we assisted with actually an internal appeal issue. This is a consumer who emailed us and was having issues getting an expedited internal appeal at her health plan. So we stepped in and sort of made that happen for her. I made sure the insurance company was doing what it should have been doing in that case. And it highlights just the, not the numbers exactly, but just the people that come through OPP and really receive a good service from us, and we try to help them in any way we can. And if we can't, we definitely refer to other state agencies and other advocacy organizations that can assist. Also have some operational updates. With our sort of increase in volume, we have increased staff support, so we were able to hire a new staff member towards the end of 2019, which has been very helpful for sort of the additional calls, the additional waivers, and some of the other administrative work that we have going on. We also take great care to partner with external review agencies that are able to sort of do the medical clinical work of OPP, and we contracted in 2018 with 4 external review agencies that are nationally accredited to do that work for us and continue to sort of bolster those relationships so that we get good decisions and good outcomes for the health plans and for the patients. And then most exciting, in 2020, we hope to transition our online forums and our online consumer resources to the website. We have a website with a lot of information on it, but now in order for patients to reach us, they need to reach us through basically mail or fax. But we are going to have these online forums, and it's going to be, I think, a lot easier for people to access our services. So that will be really exciting, and we hope to have that up and live by the end of the spring. And another big piece of OPP's work is just ongoing collaboration with state agencies and health plans and the risk-bearing provider organizations and patient advocates. And we, do this work every day and communicate particularly with the Division of Insurance on our health insurance work and with the connector on our open enrollment waiver work. Really is a partnership with each one of these groups represented on the slide to get our work done. So I can see if there's any questions about the report. Yeah.
Nancy, just a quick question on the risk-bearing organizations, ACOs, on the 55 internal appeals. Do you have a breakdown on what was med-surg versus behavioral health on those?
I don't think we request that information particularly. We request sort of which category, but I don't think we at this time request sort of what particular service or type of service, but that's something that we could definitely.
Thank you. Thank you very much, Nancy.
Well, I just want to give another credit to the Office of Patient Protection led by Nancy. This is a small team within the HPC that fields thousands of consumer inquiries every year. So you can do the math and think about what that means for a typical day, and do it with compassion and professionalism. But I think also speaks to our next topic, which we'll hit in the last 10 minutes here, which is that consumers are very confused and struggling with how to navigate our healthcare system due to the extreme complexity in administrative processes and burden. So we try to help patients as much as possible on a one-by-one basis through this part of our work. But we're also thinking about how we can maybe make some recommendations to improve the overall healthcare system. That's going to be Cara Vidal, our Associate Director, who is going to step in here and just give us an update on our administrative complexity work.
Nice segue. Thank you, Nancy. And good morning, Commissioners. It's been a little while since we have talked about this work, so just to give you the briefest reminder, over the last year or so, our primary goal of this project has been to familiarize ourselves with the literature on administrative complexity, take the temperature of payers and providers in Massachusetts on this issue, and to try to define what constitutes complexity without value, because as this committee and the board has discussed in the past, there are some elements of complexity that can add value, that can help improve quality or that can lower costs. So we've really been trying to narrow in on administrative complexity that doesn't have value. And so we have on this slide 4 potential markers that we've been using, but if you have thoughts on other markers, we'd be happy to hear those as well. And so those are activities that take clinician time away from patients, activities that have to be repeated or done differently to accommodate non-standard forms or processes, activities that may be constrained by technological limitations, and areas where the cost to perform the task outweighs the financial benefits of the task itself. So those may look familiar. We've shared those with you before. The one thing we have added to this slide is not a marker of administrative complexity, but a characteristic that we think some of these topics share, which is that a lot of these issues could be addressed without actually lowering costs to the system or getting those savings back into the hands of consumers through lower premiums. But that is a very important part of this project and of the work of the HPC, obviously. So we just want to be cognizant of that fact as we're working through this project. So recognizing that administrative complexity is a very broad area, and that both the drivers of complexity and the potential solutions vary quite a bit from topic area to topic area, we're proposing to really focus our efforts over the next weeks to months on one area, and that is prior authorization. And there are really three reasons why we've settled on that topic. The first is that when we surveyed stakeholders in Massachusetts, it was a top priority area both for providers as well as for the advisory council. It's also been getting a lot of attention nationally. There's a lot of conversation happening on this area, so it's a hot issue. It's also an area that directly impacts patients, which I think is important too. We've talked about some other areas that are absolutely defined by a lot of these same markers of complexity without value, but that don't touch patients quite as directly. And then third, it really does, we think, exemplify the markers on this slide as well as a lot of the problems with other areas of administrative complexity. So just to apply our markers to prior authorization specifically in terms of taking time away from patients, there's good evidence both from surveys of providers as well as from the academic literature that prior authorizations can take 15 to 20 hours of time per physician per week to complete. That's not all physician time necessarily, but a lot of it is nursing time, some non-clinical time as well, all of which is time sort of not spent with the patient. In terms of repeating processes, I think this really gets to the heart of this issue for a lot of providers. The services that require prior authorization, the processes for requesting prior authorization, and in some cases the forms can vary across payers. We do have a law in Massachusetts that requires a standard form. The Division of Insurance has been working on standardizing those forms, and they have done so for several areas, radiology and behavioral health, and a few others, but they have not gotten to the large category of med-surg. So there are different forms still in use, and that, of course, is one of the drivers of this inefficient process. On the technological side, again, an area where we certainly hear of use of fax still occurring, phone calls in certain circumstances. Payers tend to have web portals, which I think is an improvement over fax, but still requires that providers use a different portal for each payer when they need a request. And there's a lot of promise in the area of technical capacity to address this issue. Unfortunately, it's just slow. It's not right around the corner. One thing we hear a lot about is using artificial intelligence so that you could get the computer to read the electronic health record and make a decision automatically on whether or not prior authorization would be granted. And that's a real possibility, but from what we've heard, that's going to require each individual payer-provider combination to configure their EHR, and so it's just not as easy to do as we'd like. And then finally, in terms of the cost, this is like a trickier area because as we'll talk about over time, I'm sure, prior authorization is a tool for utilization management to help make sure that the tests and services being ordered are both the appropriate care for the patient and the cost-effective care as well. So prior authorization does likely have some cost benefits, but they're not necessarily shared between all of the parties, and we don't know that provider costs to comply with prior authorization programs have been factored into the discussion so far. So hoping to learn a little bit about that. And as we mentioned, another area where there are ways where you could simplify the administrative complexity that might not push any savings back to consumers. So we still want to be cognizant of that consideration going forward. All of this is to say that we're hoping to spend the next several weeks to months further investigating this question. And really, we have two open questions that we'd like to answer. The first is, can we confirm with data our assumptions that prior authorization as a strategy can help reduce inappropriate utilization and costs, but that it is not currently being done in the most efficient way possible? And can we identify alternative approaches that would be more efficient? And so some of the areas where we've begun to look, and please, commissioners, add to this list, are how are state and national programs approaching prior authorization? What is Medicare doing? MassHealth, the Veterans Affairs? What are other countries doing as it relates to utilization management? Do they use prior authorization or a similar process? If not, why not? What do they have in place of it? And then what has the market sort of come up with to reform the process? So we've talked a little bit about those gold carding delegation to ACOs, electronic prior authorization, practice pattern trends. And so we're hoping to come back to you in the spring with quite a bit of knowledge about prior authorization and what could be done to improve it.
So let me start off with a couple of comments. One is, I think this is very good. So as you know, I know a small amount about this issue, which is kind of like most things in life, the less you know, the stronger you can hold your opinions on it. So I'll say all my opinions as super strongly because obviously they must be correct. I'm not concerned. Concerned is the wrong word. I don't want us to aim too small here. And one of my fears is that we'll do a lot of stuff but not have a lot of impact, and then people will get discouraged. So my understanding is you're exactly right. There are some things that can be done in prior authorization before one tackles all the big issues, and I think you've listed some of them, and I have a few other suggestions which I can give you. But I also think it would be helpful for us to lay out what step 2 is and step 3 is and so on. And one possibility is maybe for this fall's cost trends hearings, maybe we can plan on trying to lay out what would be the multi-step process for the Commonwealth of Massachusetts to address administrative costs, where we've started in the prior authorization and we give an update on what we've done in prior authorization, but where we also lay out what steps 2 and 3 and 4 are, including which ones would require legislation, which ones are technologically ready to be done now, which ones are not technologically ripe yet but ought to be in the near future, and so on. So I think that sort of seeing the whole picture and where we could go can make it easier sometimes to do some of those steps, because I worry that folks will otherwise get discouraged by a lot of effort on something that then has some impact, but it doesn't solve their problem in that way. And as I say that with the absolute total conviction that I'm absolutely right. How could I?
I don't know that I'm prepared to think about next fall's cost trends hearings in January. I will add it to the list. No, the comment is well taken. Thank you, Commissioner. I do have one final slide to present, and then we can close this meeting. Just wanted to give an update on the drug pricing review regulatory development timeline. So since the board last met in November to advance a proposed regulation for the Drug Pricing Review Authority of the HPC, we did hold a public hearing on December 13th. Thank you, some of the commissioners who were in attendance. We've received a number of both oral comments at that hearing, but also written comments from a number of organizations. So those are all posted on our website. If you go to our website, there's a nice big button there that says Drug Pricing Review. If you are interested in reviewing any of those comments, they are there. We are still working towards a goal of being able to present a final regulation for the board's consideration on the next board meeting on February 5th. So some work to get us to that point as we think about potential modifications to the proposed regulation based on comments and other input and feedback. But this is just one to give this timeline update to you. And then finally, for the public and for everyone, an update on our calendar for 2020.
Having taken 2 minutes of my colleague's time, I ask for forgiveness and I declare our meeting over.
So we're going to take a good 5-minute break here and reset for the Care Delivery and Transformation Committee meeting. But thank you.
Weeks in. Welcome to this morning's meeting, and I'm going to officially call the meeting to order and then turn to Kelly for our Mass Funding Opportunity Update. You know what? We should do the minutes, shouldn't we? Yes. Okay, let's do the minutes. Is there any discussion or recommendations for change to the minutes?
Move to accept.
Motion has been moved to accept. Is there a second?
Second.
Thank you. Moved and seconded. All those in favor? Aye. Okay. Okay, Kelly.
All right, I will pick it up from here. So good morning, commissioners. Good morning, everyone who's joined us today. Happy New Year. We're very excited to be back. We're full of vim and vigor for the beginning of 2020 on a number of interesting programs. And I'm going to start by introducing my colleague, Courtney Anderson, to, as Barbara mentioned, provide an update on where we are with the MassUp investment program. In the past, you have heard from me and you've heard from my colleague, Catherine Harrison, about the program, but I do want to acknowledge that Courtney has been doing much of the day in and day out work to keep us on track. So she'll be able to provide a very specific update on where we are and what's next. Courtney?
Great, thank you. Good morning, commissioners.
Good morning.
As Kelly just previewed, I'll give some updates and milestones about what's happening with the MassUp program and describe what's coming up next. So as a brief overview, the MassUp investment program is a component of a broader MassUp initiative that reflects a collaboration across state agencies. So the agencies are the Department of Public Health, MassHealth, the Attorney General's Office, the Executive Office of Elder Affairs, and the HBC. So this initiative seeks to collaborate towards a shared vision of better health, lower costs, and reduced health inequities through enabling effective partnerships between government, healthcare systems, and communities to address the social determinants of health. So the HBC and the DPH are taking the lead on the investment program specifically. Last time we described MassUp at a committee meeting, we were still in the early design stage of this investment program, and at the time we were interviewing organizations who were doing similar work around the country. We also released a request for information where we received about 50 responses from stakeholders throughout the state. So this feedback was incredibly helpful and really helped inform many design decisions for the MassUp investment program. So we're happy to announce that we released the MassUp request for proposals. Oh, Kelly, you want to go back one more? Thanks. On December 17th, so about a month ago, the RFP solicits proposals from applicants, which are Massachusetts provider organizations, and their partners seeking support to form a partnership that will work to address upstream challenges to community health and health equity. What we're asking partnerships to do is work upstream towards systems level change to a social determinant of health that has a negative impact on the health of a given geographic community. From what we're seeing, the RFP is already generating a lot of interest. So I'd like to take some time to highlight 4 key concepts of the MassUp investment program. First, the award basics. We have a total of $2 million for funding this program. We'll grant approximately 3 to 4 awards of up to $650,000 each for a period of performance of approximately 36 months. The period of performance includes 2 phases, a planning period of up to 6 months and an implementation period of 30 months. Another key concept embedded into the program is partnerships. At a minimum, each proposal needs to include at least 1 eligible healthcare provider and 1 community-based organization. Partnerships may include additional healthcare providers, CBOs, and other types of organizations, and we encourage the applicants and partners to think carefully about who may comprise their partnership. Another important requirement related to partnerships is that an applicant and at least 1 partner organization have some prior experience working together. We're not prescriptive about what this experience is, but we believe that some foundation of a relationship will be a benefit to doing this work. Community engagement is also another critical component of the RFP. We expect the design and implementation of this program to be thoroughly informed by the voices and perspectives of people in the community that they're working to address. The partnership must seek input from and give voice to the communities it intends to serve through all phases of the work, including design and implementation. Finally, governance is another important facet of this work. All proposals must describe a governance structure that will set the strategic direction of the partnership. And we're not prescriptive about what a governance structure will be or what it'll look like, but we do expect all of them to be constructed intentionally to create equity and accountability among all of the partners. So the coming months will be very exciting as we move through the procurement process. We're in the middle of an open procurement period. Last Thursday, we hosted an information session webinar for interested stakeholders, which I'll talk about quickly on the next slide. We're currently receiving questions from interested stakeholders and have established a frequently asked questions process where we'll publish official responses to the questions onto the procurement website, Combis. Proposals are due in a little over a month on February 21st. And at that point, we'll establish a selection committee to review the proposals. The team will present our recommended awards for board approval on April 1st at the HPC board meeting, and then we'll hope to begin contracting immediately and aiming to launch the program in June. So before I close, I just want to quickly highlight the information session webinar we had last week. We reviewed key features of the MassUp RFP, similar to what I just described to you all. And it was well attended. We have had over 170 viewers, including representatives from provider organizations, community-based orgs, advocacy groups, and local government. And colleagues from our other MassUp state agencies also joined us on the webinar. We were able to answer some direct questions about the RFP on the webinar, and we had 58 questions during the hour-long webinar, which I think is really indicative of the great interest this program is that we're seeing for the program. So we're looking forward to the procurement process and seeing who applies in February. Before I turn it over to Mike to talk about ACO certification, can I answer any questions?
Courtney, on the time period, the 36 months, is there any time towards the end for a specific planned evaluation process?
Yes, so DPH is going to be helping us with the evaluation program itself, and that includes some time afterwards where we'll do a thorough analysis of the success of the program.
And does that include any discussion about dissemination of findings?
Yes, I think built into the program and part of what we have written in the RFP is an expectation that awardees will provide information that we then can disseminate out into the world through our L&D process.
Okay, thank you. Any other questions? Okay, thank you, Courtney.
Thank you.
Okay, thanks, Courtney, and thanks for the tip-off to your colleague sitting next to you, Mike. When Courtney isn't working on MassUp, one of the other things she does is work on ACO certification with Mike Stanek. Shortly before the end of 2019, the HPC successfully completed its second round of ACO certifications. As I mentioned, leading that effort were two members of the Healthcare Transformation and Innovation team, Mike and Courtney. Mike is going to share the results of this year's certification, also some high-level findings and next steps. With that, turn it over to Mike.
Thank you, Kelly. Good morning, Commissioners. Good morning. When we last provided an update on the HPC's Accountable Care Organization certification program, we were in the process of reviewing applications from 14 organizations. And I'm very pleased to announce that all 14 of those ACOs have met our certification criteria. And as you can see here, those are Atrius Health, Baycare Health Partners, Beth Israel Lahey Performance Network, BMC Health System, Cambridge Health Alliance, Children's Medical Center Corporation, Community Care Cooperative, the Mercy Hospital, which is part of the Trinity Health of New England system, Partners Healthcare System, Reliant Medical Group, Signature Healthcare, South Coast Health System, Steward Healthcare Network, and Wellforce. Each of the certified ACOs here was either originally certified by the HPC in 2017, or it consists of components that were certified in 2017. So for instance, the Beth Israel Lahey Performance Network is newly certified this year, but component entities like the Beth Israel Deaconess Care Organization and Lahey Clinical Performance Network were certified separately by the HPC in 2017. Certification is effective for 2 years. And as a reminder, the current total number of HPC certified ACOs is 17. So in addition to the 14 ACOs certified or recertified in 2019, 3 additional HBC certified ACOs are eligible for recertification this year. And those, as you can see, are a Health Collaborative of the Berkshires, which is a partnership that includes Berkshire Health Systems and Community Health Programs, Merrimack Valley ACO, which is a collaboration including Lawrence General Hospital and Greater Lawrence Family Health Center, and Mount Auburn Cambridge Independent Practice Next Generation ACO program to the Medicare Shared Savings Program. We've seen that contracts with downside risk have increased modestly, I think by about 10 out of 100 or so total contracts. And the number of upside-only contracts has similarly fallen by about 10. PPO risk contracts have increased only very slightly from 8 to 10 since last time. So a key goal of the ACO certification program is to bring transparency to the market regarding what ACOs are, how they operate, and how they provide care for patients. In addition, the HBC is always interested in creating opportunities for provider organizations to understand and benchmark what they're doing in the context of their peers. You'll recall that following our first round of certification, we pursued a learning and dissemination strategy based on producing timely, high-quality, comprehensive products with salience to stakeholder interests. We published profiles of each HBC certified ACO. We convened a webinar on ACO approaches to delivering serious illness care, and we released a series of policy briefs. These briefs documented ACO characteristics, their strategies and activities for managing population health, and the nature of risk contracts ACOs hold with payers. As I mentioned, in the coming weeks, we'll be analyzing the data and information submitted during the recently concluded round of certifications to inform future outputs. As you can see here, the HBC can publicly report a few data elements for individual ACOs without prior consent. These are things like basic contact information, like the ACO's name, street address, and primary contact, lists of ACO participants, either submitted by the ACO or determined by the HBC through the Registered Provider Organization filings, names of payers with which applicants and component ACOs have quality-based risk contracts, the year that each current contract began and expires, whether the contract is upside only or has two-sided risk, and the number of attributed patients per contract. We can also publicly report on things like the positions of patient and consumer representatives within the governance structure excuse me, of the ACOs, descriptions of patient and family advisory committees, and public narratives demonstrating how the governance structure seeks to be responsive to patient population needs. However, most ACO certification application content can be publicly reported by the HBC only in the aggregate, de-identified. So that includes things like more detailed information about risk contracts, including product types included, years of risk experience with the payer, financial terms like maximum risk, and payment methodologies in use. Also includes things like descriptions of population health management programs, addressing behavioral health and social determinants of health, methodologies for distributing shared savings and losses under risk contracts, approaches to using performance-based compensation models, strategies for addressing areas of low-value care, identified in previous HBC cost trends reports, and strategies for supporting advanced primary care and integrating behavioral health into primary care. So more to come on this as we continue combing through the data and developing a learning and dissemination strategy. But I'm happy to take any questions you have on the program or the process.
Okay. Thank you, Michael.
Thank you.
All right. Take a second and resituate. So as many of you are aware, the HPC has played a significant role in supporting efforts to address the effects of the opioid crisis on the citizens of the Commonwealth. On the investment side of our work, we've supported a number of different opioid-focused efforts across the continuum of care. Adrian Anderson, who's going to speak with us today, has been involved in many of those efforts, most recently as the lead on our Shift Care track, focused on medically assisted treatment in the ED. And she's here today to speak about a new investment program that is in development, but we're really enthusiastic about, specifically focused on substance-exposed newborns. So with that, let me turn it over to Adrian.
Thank you, Kelly.
Thank you all, commissioners. Begin by talking a little bit about some of the related past work to contextualize some of this newer work. So this slide here visualizes HPC's recent investments in neonatal abstinence syndrome care, often administered in partnership with the Massachusetts Department of Public Health. And the HPC has certainly learned from designing, implementing, and evaluating these care models, and now sees an opportunity, particularly in the far right-hand column at the post-discharge, 6 months post-discharge period, further into the life course, to invest in an opportunity to improve care for substance-exposed newborns and their families at a time when we know services often taper off and present risk, especially to the mother. In this presentation, we'll describe what we've heard providers still need to bolster the outpatient follow-up care and to improve integration of the care continuum. The purpose of our next investment is, in large part, to extend the impact of previous investments, to build upon the infrastructure that's been established through previous investments, and to sustain those most successful elements. Specifically to support Massachusetts providers in implementing models of care and services that emphasize behavioral, social, and medical needs integration beyond the hospital, after discharge, and into the life course a bit beyond. To better understand the landscape of efforts across the Commonwealth in this space, the HPC engaged a variety of stakeholders, including our colleagues at the Massachusetts Department of Public Health, the Perinatal Neonatal Quality Improvement Network, the American Academy of Pediatrics Massachusetts chapter, and a variety of local providers as well. Our conversations with stakeholders produced useful feedback that both validated the potential value of this investment and raised important considerations for us in designing this program. To the former, stakeholders emphasized the importance of an opportunity present in focusing on investments beyond the postpartum, 6 months postpartum period. Some of the stakeholders with whom we spoke were responsible for research, in fact, that's demonstrated specific time periods of vulnerability, especially, as I mentioned earlier, for mothers postpartum, and that's often between 6 and 12 months postpartum. Many providers, especially those who had worked on previous neonatal abstinence syndrome investments, have effectively coordinated, in response to fragmentation, coordinated services between children and their parents in a way that I think ongoing literature will demonstrate improves continuity of care from prenatal to inpatient and beyond services. All of the stakeholders referred to the importance of early intervention providers, social service agencies, and other local organizations with whom they work closely, and claimed that would be important to an effective investment program. Investment in targeted models could also help facilitate additional study of the clinical outcomes associated with substance-exposed newborns, which to date has been limited. With respect to clinical and operational considerations raised in stakeholder conversations, there's been insufficient evidence, as I just mentioned, and therefore no standard of care or clinical protocol exists, especially for this population, and that's challenged providers for years. Mothers' experiences of stigma, especially in medical settings, and their fear of separation from their children complicates the delivery of care and services around medical care. There have been a few promising models, which I'll describe in a moment, which have been funded by donations, small grants, or reserved funds from system margins, which is a challenging prospect for some of the systems that have fewer resources. Local providers also mentioned workforce challenges as potential barriers to implementing models such as those I'll describe in a moment, specifically in child psychiatry and certainly in primary care as well. And finally, it's important to define a target population that is both specific enough to institute sort of a pilot type program, but also not so specific to exclude potentially appropriate patients who could really benefit from a program like this. Thanks. So these are the two models I was alluding to earlier. On the left is the SOFAR program at Boston Medical Center, and on the right, the Hope Clinic at MGH. So these are both academic medical center based. They both provide services both for mothers and for infants, in some cases additional family members as well. On the left is a pediatric-focused model that offers care additionally for women in the postpartum period, care coordination, peer supports, and on the right, a more maternal-focused model that also offers psychiatry and medication for addiction treatment to moms, as well as peer support and some of the core functions, primary care, linkage to early intervention, and the like. These programs, interestingly, I think have been largely self-motivated. Providers have observed and reacted to needs they've identified in clinical practice. These have been homegrown initiatives based on those experiences. So we've met with some of the providers from these clinics, and that experience has certainly informed some of the design so far. Considering stakeholder feedback and the HPC's overall approach to investments, we've laid out some key principles here to inform our proposal and eventually the procurement process as well. First, supporting providers creating or expanding upon existing integrated models of care, funding coordinated multidisciplinary programs that might include primary care, OB-GYN, early intervention, and other social services in a multidisciplinary fashion. Fostering sustainable clinical and community partnerships to improve care for substance-exposed newborns, whether that's focusing on bolstering the continuum from inpatient to post-discharge care, or augmenting formal or informal or both relationships and partnerships between healthcare and other types of organizations, and coordinating appropriate responses accordingly. Additionally, the importance of addressing the unique features of the population, namely stigma in the case of moms in the target population as a persistent barrier to ongoing high-quality care, and the unique situation of caring for two patients at once and the nuance that presents for care delivery. And finally, the importance of aligning with other efforts, both our own past investments and that of DPH and others by our colleagues throughout the Commonwealth. Here's an overview of a potential proposal. And we look forward to your feedback and questions in a moment. So to achieve the aims I've just described, the investment proposal, the proposed investment program would fund multidisciplinary, team-based integrated models, including staff and infrastructure investments at several Massachusetts providers, which might include chart-eligible and non-chart eligible hospitals, ACOs, primary care providers, and behavioral health providers, both to fund those models and staff them, and potentially to invest in the types of tools and methodologies necessary to collect and analyze data to learn more about the outcomes and needs of their patients in this population. And finally, on this slide, the HPC would potentially engage a contractor to support technical assistance and evaluation activities related to this investment program. Finally, this slide lists a variety of potential investment areas and services we might anticipate applicants proposing based on our stakeholder conversations and some of the needs we've identified as themes in those conversations. So walking through those, try to move counterclockwise, building capacity to support recovering parents in pediatric settings, helping patients overcome logistical barriers such as transportation to and from appointments and coordinating appointments with their children's appointments, or vice versa. Promoting partnerships to enhance integration of medical, behavioral, and social services, implementing validated screening tools and developmental assessments, offering home-based services in social work, medical care, and peer supports, tracking and following patients post-discharge, and finally building capacity to support recovering parents in pediatric settings. I think I started there, I'm sorry. So those are just a sampling of some of the concrete ideas we might expect seen in the proposals. So we welcome any questions and guidance you have based on that. Thank you.
Thank you for this presentation. Just a quick question. What are some of the core roles and positions that have been critical to these models? So is it kind of like master's level, psychiatrists, or is it more of the peer support roles that have been critical?
That's a great question. I think we've heard a variety of answers. I can think of a few core roles that were common in almost every case, and that is a social worker, clinical social worker, who sometimes also provides navigation type services and care coordination services, but can also serve, the true clinical social work role. Also a care navigator, care coordinator type function. In some cases, that might be a person who provides those services to a variety of providers who are in a partnership or in a system, sort of on a shared basis. Certainly a specialist, a physician specialist who treats, in some cases, has a pediatric focus or maybe has a focus on moms, but in either case, they sort of build the program around existing roles and which team members have availability, that sort of thing. So we've seen a few types of models manifest, but I think those are probably the core roles. I'll see if Kelly has other additions.
I think that's very consistent with the feedback we heard on the phone calls.
I think this is great, and I think it builds on the prior work, which I think is important. I worry a little bit about, and you have it here, the integration between hospital social services, behavioral health, community providers. Just because of the flow, and so just obviously you honed in on that, but I think that's going to be critical to the review of the proposals. And my assumption is you're taking applicants beyond those that we have funded previously.
That's correct. Thank you.
So just a note about the kind of the funding here. This was a mandate that the HPC developed this program in consultation with the Department of Public Health. It was part of opioid legislation that I believe was passed in 2018. And then in the most recent state budget, the legislature did approve $250,000 to be able to be applied for this program. I think that the mandate is quite broad in terms of the legislative language, and so as Kelly and Adrian have talked about, how do we really kind of craft a program around this that fits with all of the principles that we've laid out. I would also note that we are considering perhaps applying some additional resources to this beyond the $250,000 that was included in the budget, because we do have some surplus dollars that are in our kind of distressed hospital trust fund, and so the idea would, given that we are hearing a lot of interest from organizations to be able to do this, it would be great to be able to maybe supplement that funding a little bit so that we could have a couple applicants and awardees as opposed to perhaps just one or two with the money in the budget. So no firm decisions there, but we do see a lot of interest and a lot of need. And so if we're going to be, we saw this maybe an opportunity to kind of bolster some of those resources to be able to provide, again, to have multiple awardees across the Commonwealth.
Thanks. Yeah, just an additional note on that, and Adrian is certainly more a veteran of this space than I am, but I will say one of the things that's been really, really interesting in sitting in on these calls and even understanding some of the more evolved programs like the ones Adrian described is at this point it really does feel like many of these programs are truly a labor of love, on behalf of the people who found them. Even at the more well-resourced institutions, they're doing this work on a shoestring because they believe in it and they think it's really important. So we were really pleased to that David was open to considering some additional funding because it does feel like it's needed, and it's needed, across the board, in all sorts of different settings. So we're anxious to take these principles and then probably over the next month or so kind of do that next level of refinement so we can, characterize all the components of an investment program and then move on to approval and procurement and all of the other necessary steps.
Okay, thank you, Adrian. Great work.
Thanks.
Thank you, Kelly. Okay, we are now at that point in our agenda where we are going to hear some very exciting thoughts and information from Hebrew Senior Life. So I think we need to get you set up.
Yep, we can get you set up. Why don't you go down that direction? And while you do that, let me just say, just to build on Barbara's comments, I'm very lucky. I get to sit here and I have the privilege of speaking to the impact of our investment programs on a pretty regular basis. But I know both from my personal experience and from your feedback that the opportunity to hear directly from our awardees is really precious. So with that, I am going to invite my colleague, Molly, whoops, I'm going to get out of this seat because it looks like we're running out of space, to introduce the team from Hebrew Senior Life and the program that they have launched.
Okay, it's all yours, Molly.
Thank you. Thank you so much, Kelly, and good morning, commissioners. My name is Molly Sass. I'm the Senior Program Associate on the HICT team, and I'm pleased to introduce the Hebrew Senior Life team. This is the first Shift Care team from the Health-Related Social Needs track to present their work to you. This is Hebrew Senior Life's second investment program with the HPC. In September 2017, HSL presented on behalf of their HCII investment program called R3. Shift Care has given the HSL team an opportunity to expand and advance their R3 program that began in HCII. Today, HSL will be presenting a little bit on R3 and then really diving into their Shift Care investment program called R3 Squared. Before I hand this over, though, I would like to briefly remind everyone about the Shift Care competitive grant. We awarded 15 healthcare sites across the state awards up to $750,000 for innovative care models focused on health-related social needs, timely access to behavioral health, and evidence-based OUD care. The HRSN awardees target a range of patient needs, including housing, food insecurity, nutrition, transportation, and employment, while also working to reduce avoidable acute care use. While the majority of awardees are about halfway through their 18-month implementation period, HSL is in their 13th month. The HSL team has been forward-facing, strategizing about the sustainability of R3 and R3 Squared since the beginning of their work in 2017, and it's been a true honor to be their program contact. They're represented today by Lou Wolf, President and CEO, Kim Brooks, Chief Operating Officer for Senior Living and Investment Director for the HPC Investment Programs, and Stephanie Small, Executive Director of Simon C. Fireman Community and Program Director for the HPC Investment Programs. So with that, I turn it over.
Great. Thanks, Molly, and thanks for this opportunity. So I'm just going to kick us off with a very quick context and then turn it over to Stephanie and Kim. So Hebrew Senior Life is a nonprofit organization, Harvard Medical School affiliated senior care organization that has approximately 2,600 employees caring for about 3,500 seniors on a daily basis across 9 communities and increasingly in people's homes. This slide is just a quick snapshot of the extensive breadth of our services. And you can see in senior living ranges from independent living to assisted living, market rate and affordable, healthcare, institutional care, as well as a wide array of home and community-based services, and an extensive amount of research and teaching around seniors. The importance of this snapshot is that we are an organization that offers such a breadth of services that we really are in a position to focus on what's best for people and what's best for the Commonwealth, and that really is our goal, as opposed to out there selling a particular service and trying to fit a square peg in a round hole. The next slide, the organization actually was founded 117 years ago, but the catalyst for this breadth of services was really in the mid-60s when the current Hebrew Rehab Center was built, 700 beds of nursing home care, and immediately was filled and had a 500-person waiting list. So research was immediately taken to really look into how could this population be better served in the community, in supportive housing, and really to achieve what we now call the triple aim. We now have a situation where we have 1,000 people in affordable housing with services, and it's estimated by assessments we've done that at least 1/3 of those people would be in nursing homes if it weren't for this model of affordable care and services, at not only a lower quality of life, but a cost of over $30 million to Mass Health that we are saving annually. So it really is, our conviction and our belief in this model is really what it was the catalyst for, what we're going to be talking about today is R3. So I now, with that context, turn it over to Kim and Stephanie.
So we're going to thank you for the opportunity to present today. We're going to really spend our time just framing a little bit about the opportunity and the problem we're trying to solve, and then an overview of R3 and the work that we've been doing, and then how that set us up for R3 Squared. So right care, right place, right time, and again, all about the integration of housing and care. So we, excuse me, we feel like we have this really unique opportunity to take advantage of the efficiencies and the economies that come with thousands of seniors living under, a handful of roofs across the Commonwealth, and Really, the system is not set up in a way that takes advantage of that. So, there are a lot of payers covering the lives in those multiple buildings, and not a lot of them have critical mass. It also has resulted in a lot of inefficient service delivery, multiple care managers coming in and out, multiple home care providers coming in and out, no ability to really connect with and get all the great information that the housing teams have. And lastly, over the years, the health plans have said that they believe that there's great value in this model, but there's never been an evidence base to really do anything with that. So a lot of this has been about creating the evidence. The house kind of just shows you our big vision for the overall program, and it's all about getting the health plans together to pool some resources and preventatively spend a little money on the front end for the big savings on the back end. We have the core of the R3 model is this whole enhanced supportive services team, a wellness team made up of a coordinator and a nurse embedded in housing, partnering with the small housing staff, delivering interventions like, noticing when things are happening and communicating early about those, and connecting people with the resources that they need early on to prevent a crisis, doing care transitions management, connecting them with community resources, and really all those preventative wellness education and other activities to keep them well at home. That all resulting in much better outcomes and certainly savings to the overall healthcare system. So our overall just funding scope, and then to start to delineate between R3 and R3 squared, we used the initial funding that we received from you from the HCII program to leverage a lot of additional funds. So you see there the lengthy list of people who have been engaged and who have contributed to this work, which allowed us to have 7 sites in the intervention. So we have 7 affordable housing sites. Some of them are Hebrew Senior Life, very service-enriched models. Some of them are owned by a for-profit provider and some by another nonprofit with less services. And that's been a really great way to test it in different environments. And across those sites, we have 1,100 seniors living in those buildings that the teams are working with to some degree across all of those. And we've broken that up into 2 regions so that we can also test across the regions. That funding also allowed us to engage the Leading Age Long-Term Services and Support Center at UMass Boston to conduct a full evaluation. The Shift Care funding has now allowed us to use what we learned in the first round of that evaluation and really expand on it, extend it, also have more time to continue the interventions, enhance the interventions, learn from all of that, and then really focus on the sustainability. So I'm going to turn it over to Stephanie to talk a little bit about the results that we had from the initial work and how that led to the key components of R3 squared.
Thank you. So as Kim mentioned, we have UMass doing a pretty thorough assessment and analysis of all the work that we've done, and we will have a much larger evidence base to present you when they're done with their report, but we wanted to give you a couple key pieces. From a quantitative perspective, what we are most excited about was the ability to reduce trips to the emergency room via ambulance, and I'll just say that we have a fabulous partnership with first responders for this program, and they've been giving us not just data on how many trips, but also time of day, day of the week, reason codes. And we're able to not only look at trends, but also they're giving it to us pretty much in real time, so we're able to use the data to help specific residents. It's been quite a wonderful partnership. So we were able to, you'll see in the box down at the bottom left, during our intervention period, in R3, we were able to show an 18.6% reduction across our 7 sites in trips to the emergency room compared to our baseline year from the year before. So we were very excited about that. We are continuing in R3 squared to try to show another reduction of that same size. On a qualitative, level, I'll just make a brief note. The UMass folks also did some focus groups with residents to ask them about their experience of the program, and you can see some of their comments up there. One of the themes that we heard that was interesting was we added as part of the care model for the teams to reach out every single month to all 400 enrolled residents, either in person or by phone. And we weren't sure it was that good of a thing to add. The residents loved it. They basically felt like even if they didn't need any support, the fact that they knew that someone was going to call and check in on them was very beneficial. So, and you can skip that one. I think you've covered that. So, as we transitioned into R3 squared, really what we were focusing on is in R3, what we noticed was some very significant issues that were causing seniors to transition from independent living to nursing homes prematurely. And so we really wanted to target those areas. And so we did very thorough assessments with all 400 seniors, and then we did some risk stratification and really identified these areas, mental health and cognition being very significant, as well as nutrition and food insecurity, which were also causing some significant problems. Our teams then set about trying to figure out how to meet the needs of all of the residents who had issues in these particular areas. And we did a few things programmatically to address that. One of which was we got a contract with Brookline Mental Health Center so that they would have a therapist come on site to provide individual therapy to residents, taking away the barrier around transportation and missed appointments. We also have engaged a nutritionist who's doing some individual work with residents. And we've had a few residents who actually are having trips to the ER because they're not eating well enough for their medical conditions. So it was sort of another way to try and address some of those issues. This slide is to show you what our teams are working on concretely, which is closing that gap. So you'll just see if you look at mental health, we've identified in Brookline, well, in both regions, over 100 of our seniors need some sort of mental health supports. That's a pretty big number. But if you add those two together, that's more than half of the 400. They don't all need the same service, but they all need something. And so the team's job is to sit with each one of them, figure out what they need, and then find them that support. I will just note that you'll see the dark gray bar is our homework. That's what we're trying to get to. The blue is how far we've gotten. The gray are people we've reached out to. That includes the ones who said yes, and the people we reached out to who said, I don't want service, which in mental health, and also as people's cognitive functioning starts to change, we find sometimes people really are not ready to receive the supports. So the last thing I will just say before I give it to Kim is that one of the interesting things that we've really noted that's important about this program is having the teams be embedded in the housing sites. That a lot of the seniors we find as they start to frail, they don't want to be a burden to their adult children or their families. They don't want to tell their primary care doctor or their case manager who calls them that they are falling, that they don't have food, that they're struggling. Because our teams are seeing them in the hall every day, they see there's a bruise on your arm that wasn't there yesterday, or they're in their apartment and they know there's no food. And so the value of them being on site is just really a significant key component.
Which I think leads to the sustainability discussion. That's been a big part of our focus. 3 main work streams we've had going during this R3 squared period. One around financial modeling and coming up with this pooled funding approach. Another around replicability. So we are very committed to creating a toolkit so that others can follow our work and really package all of our resources and everything that we've done in a way that others can take advantage of it. And then infrastructure and dealing with the infrastructure issues and advocacy around that. So as it relates to financial modeling, we have spent a lot of time and energy, and I'll talk in a minute about the pooled funding approach that we've been using. That has some limitations. There are a lot of people on fee-for-service programs, meaning we haven't been able to capture everybody we need to make that system work. So we've been investigating other options while we're working on that. One, the Lauren Taylor, Len Nichols, collaborative approach to funding social determinants of health and public good, and really seeing if there's a way, because we have such strong partnerships with so many different organizations that have been engaged in this, is that a way for us to broaden the pool beyond the health plans and really think about all the stakeholders, whether it's the housing sites, the emergency responders, the towns, anybody who might have a stake that we could bring to the table. We've also been looking at a convener model, thinking about how one organization might be the catalyst to be the data repository, be the consultants, and also take some of the risk for those organizations that aren't ready or willing to do that. And then across all of those options, thinking about whether social impact bonds have a place in that, and we could layer that on to limit the risk that any one organization needs to take out of the gate. So, and I would say around infrastructure, This certainly seems like the right time. Our ability to actually show results has been a great catalyst for all these conversations. So we've been really actively engaged with the Aging Service Access Points and the SCOs and EOEA, really getting everyone trying to figure out how do we now align the infrastructure and the payment model that never, I think really, when it was created, nobody knew that there was going to be this opportunity to take advantage of place-based services. And now that we know we can have such an impact on healthcare and healthcare spending, how do we make those shifts to take advantage of that? So just to give you a sense of how challenging the pooled funding approach is, you see on the pie chart, we're making a small dent by getting a couple of the managed care providers to the table, and we've been really successful with Tufts and Commonwealth Care Alliance. They've been great partners. I'll talk about that contract in a minute in a little more detail. But you will see there that most of our residents are in fee-for-service, Medicare or Mass Health. And in those cases, we are trying to come up with existing resources that are within those systems that we can tap into to kind of count for that part of the pie. So whether it's the complex care management code that currently exists in Medicare or some of the waiver services that are already in Mass Health, trying to cobble those together to make the whole. We have had some great success with HUD in actually increasing our contract rents that come from the HUD program based on the services that we're providing and the impact that those services can have. So that, to me, tells a great story of this great intersection between housing and healthcare. On the payment model, we've used a really basic calculation to come up with a way to just get the payers to the table, really taking the total cost of our two wellness teams and adding in some of the one-time program costs and evaluation costs, coming up with a total, dividing that by the 1,100 lives across those 7 buildings we talked about, and then asking the payers to pay their fair share for the covered lives that they have in the building. We've then worked with them to come up with outcomes measures that align with their goals and ours, things like flu shots, healthcare proxies, reducing ED trips, falls prevention. And then we built in a shared risk component where 10% of that payment that they're making to us is on the table and at risk if we don't deliver on the goals that we have set. As you can see on the circle there, this really doesn't make a huge dent in the dollar amount, but more importantly, we have them at the table. So we have competitive health plans working with us to not only figure out how do we better communicate and coordinate care, but also, how can they help shape this future financing model? So as you can see, we feel like we've had some great successes. We certainly believe we have a significant amount of work left to do to get to full sustainability. We are so thankful for your investments in us and your confidence in us. The initial funding really brought what we had as a concept to life and allowed us to really get it going. And now the shift funding has allowed us to enhance it, and really come up with this permanent funding mechanism. So we certainly welcome any questions or any guidance you have for us as we move forward.
Thank you very much. That was a great presentation with a lot of encouraging information. Are there questions?
Sure, I would echo really interesting and timely as supportive housing and just housing and the intersection of healthcare really moves to the forefront in a lot of the work that I know the executive office is doing. I'm interested in hearing more about when you note that this model is replicable, scalable, and you are already taking proactive efforts to create these toolkits for other entities. What would you say is kind of the number one, or the top 2, 3 steps and kind of linchpins in creating a model like this would be for, say, a skilled nursing facility with 150 beds that, say, wanted to convert to this type of model? What are some of what would you say are the most critical linchpins to achieving that?
So interesting perspective when you talk about a skilled nursing going to it. We have geared, as we thought about the toolkit, housing sites who are not really focused on healthcare. So how do we get them to make that leap, to make the connection? But I think it would be an interesting approach also to think about how do others, either convert to or go to a more housing and healthcare model. I think the the interventions are probably the easier part, but we feel like we've done a lot of work to figure out what works best and what one doesn't need to waste their time on. So I think, coming up with the right interventions that we feel have the most impact, the data analytics and how one tracks it so that we can prove that you're actually having impact. I think the harder one is the sustainability piece and trying to give people whether it's the contracts or the approach to take with payers, or how do you convene your payers and your stakeholders, and then how do you have a financing model that they can actually wrap their head around, and again, one that would be transportable to any housing site or community or other organization that's willing to go down this path.
I also think it's been interesting that because we've been focusing on affordable housing sites, that there is a shift in thinking that those providers need to make if they're going to embrace this. And so I don't think we were thinking about it, we were thinking more about the concrete tests, but there really is a mindset shift around if you're going to embrace this, there's information that you're going to know that I think housing providers have historically thought was not their purview. And so when you start to blend those, you have to talk about things like HIPAA and how do you share information and how do you serve some residents who don't want you to know things. And so I think that piece is also something we're going to have to think about how to help providers who want to.
When you talk to housing providers who currently don't have services, they get very excited by this because they feel like, with a model like this, they would be actually doing a better job. They'd be caring for people. They would have less turnover. People would be leaving less. So that's, and all those things.
Yeah.
But so to throw something out controversial, we've talked about one of the challenges is that all the people that live in a housing site have all these different insurance programs. So insurance companies don't have critical mass. So, for all of us, when you go to work for a company, they say, okay, Tufts Health Plan is our provider, and you have like 2 or 3 choices. So if we ever could get to the point where people to live in an affordable housing site were obligated to choose a healthcare provider, like Tufts Health Plan is our provider. You can pick the SCO or you can do managed Medicare. Which would you prefer? You would then have a health plan that is incredibly committed to this, and this would, we believe, grow like wildfire. The challenge is that people moving into affordable housing, there's a big barrier to having them be forced to choose a particular health plan. So we all agree if that barrier could be overcome, that would be an amazing catalyst for this to grow.
Other questions?
I know you said most of the participants are on fee-for-service Medicare, but to me, this is a perfect sell for a Medicare Advantage program, and it sort of gets to Lou's last point. Are you talking with the carriers, and is there interest, and is it just the critical mass per site?
And I think, so we are, Tufts is a great partner because they have the SCO and the Medicare Advantage, so that's been, and we've looked at that whole population with them. We have our sights on a couple of the other Medicare Advantage plans that I do think we will be able to engage. It's really been about how many people can we get in, how quickly can we get them in, but especially with the recent changes to the Medicare Advantage and the flexibility that they have, I agree with you. I think that's going to be a great way to get more buy-in to this.
And just to clear the family name, the Cohen House has experienced a 27% increase in ambulance visits.
That is a bit of an anomaly.
It is an anomaly, and I will say there's another graph, but we tried to be concise. While that one is our own and it has an increase, the baseline is so low when you look at it comparatively. It's got a really low baseline.
But also there was a major renovation taking place there at the time that was so there was
occupied rehab's a little
big
challenging.
other factor there. So right.
I think that data is a kind of a moving target as well, because there are all sorts of intervening variables that you don't, at this stage, account for here.
Right.
You don't have necessarily the capacity to account for it here, and yet out there someplace something is partnering with you that you may not recognize or understand. Right. So my question is, what was your biggest surprise? I'm the innovation person. I'm supposed to ask these kind of questions.
That's a great question. That's a great question. What was our biggest surprise?
I guess, well, one of the biggest surprises was all of the infrastructure work. I didn't I was planning on us spending a lot of time and energy on the pooled funding piece. I didn't expect that we were going to spend the time and energy that we have on the infrastructure components, just because the system is so kind of set the way it is, and so having to get everybody to try to think very differently about the way business is conducted, the way payments happen, and maybe people will have to shift their thinking from the revenue models and the way they currently do business to a new way of doing business. And we've spent way more time and energy. I think it's been really valuable, but it was a much bigger part of the program than I expected.
Well, I think also when you take a look at what housing requirements are, and those folks that manage and create housing, their job is already quite complex, especially when you look at the funding sources that they have. To ask them to think about health, even though in their hearts and their minds they understand, and not create partnerships for them or create avenues by which they can partner with somebody who actually knows what they're talking about. If you can't offer that, then there's no way that most of them can open that door, because they have no idea how to do that or where the funding might come from. So creating those kind of partnerships and finding locations, physical locations, that are open to the concept of at least having the conversation that you can partner.
Right.
And actually get much stronger outcomes for the residents that are living in these. Most housing folks want their residents to have good, safe, high quality community, and you have to create community, and you have to create those kind of partnerships that make it easier for them to say, oh, okay, you can do it, come on.
Right.
And that's what I think is the model that you're describing and framing,
Right.
in ways that make it very doable. It's not as frightening. So congratulations,
Yeah.
because I think you've got a nice model.
Thank you. That's the basis, the convener model. And we, as far back as 5-6 years ago, we've had conversations with Tufts about if we could get this critical mass question solved, that we together could go and say, do we have a great project for you? Here's the insurer, here's the provider, you have the environment, and we're going to do a wonderful thing together. But they would need that kind of help, absolutely.
And I also think that in looking at the Advantage programs, Tufts has a very robust one. Harvard Vanguard has Harvard Pilgrim has a very robust one. There are models out there where it might well be possible to take a look at how do we capture Advantage programs and allow it to be possible for large insurers that offer that, as opposed to trying to figure out that we can only partner with this one. It would actually invite 2 or 3 companies to look at, can we create a shared model in this environment, which is an advantage for all of us. It addresses the complexity issues that the commission is engaged in and wanting to find solutions for, as well as broadens the opportunity for sustainable reimbursement models. So, things to think about. Lauren?
To the point about critical mass, is there a threshold of like a percentage number of residents that need to be under one of the commercial plans to make the model sustainable?
I would say it's probably a body count more than a percentage, given the size of the community, because some are 45 people and some are 250, but I don't know, do you have a sense?
I
of
also
what
think
the
it's more about the willingness to partner up and to work together. So I agree. It's not, some of the building, if you're talking about a 40-unit housing complex,
You need
it's going to be really challenging. But some of these buildings are a couple hundred people living under one roof. So it's not that huge of a number. And, one of our partners doesn't have that many covered lives, but they're really engaged in it because they know we can do so much of that work really efficiently on the ground.
If it's 4 providers and they each have a quarter of the people, then they lose, the question is, do they each want to control how their population is cared for, or can they all agree on a given model? So that's something we would love the opportunity to dig into more with you, and if there's an avenue to some potential solutions or trials.
It talks about shared pathways.
Right. Yeah, exactly. Exactly.
Are there any other thoughts or questions? On behalf of the commission, I want to congratulate you all. You've done some very exciting work, and we hope to hear from you on a continuing basis about the progress that you're making. So thank you
Thank you
for
very
sharing
much for
the
having
program
us.
with us.
Thank you.
Is there any other business to come before the commission? Okay, then our next scheduled meeting for everybody is May 6th. It will be springtime. It will be nicer, we hope. Thank you all very much for coming. We'll see you next time.